Okay, the technical team, they're all ready to go. And thank you all for joining us. And at this point, I'll hand over to the technical team. Thank you.
Hello there. My name is Dr. Valentine Ngwa. I'm the education lead for CamDocUK. We're quarter past, so I think it's time for us to start. Before I introduce our moderator, can I kindly do a few housekeeping? If you do have a question during the session, you can, down on your screen, there's a Q&A. You can put your questions there for the panelists, and that could be answered either directly to you or live on during the webinar. And without much ado, can I kindly introduce our moderator for tonight, which is our 18th CamDoc webinar, speaking to the community. And as you know, tonight we'll be talking about mental health in sickle cell. And there's no one fit enough to be our moderator than Dr. Asa'ah Nkohkwo, who, if I start introducing him, will be very too long. I would make it short. He's a consultant clinical scientist and a public health consultant. He also the MD for Team Caritas, which some of you will know is a hospital avoidance project for the NHS. In the sickle cell world, he is a former CEO and specialist advisor for Sickle Cell Society. And he is also the former WHO panelist on blood and genetic disorders. As I said, if I carry on, we might stay here tonight. But he comes here today with a lot of expertise and knowledge. And it is my honor to introduce Dr. Asa'ah Nkohkwo, who will be our moderator for tonight. Thank you.
Thank you, Dr. Ngwa, for that wonderful introduction. Yes, Chief Asa'ah here. And it's wonderful to see so many people joining us this afternoon or late afternoon as from London. Wherever you are in the US, in Africa, in Europe, Middle East, thank you all for joining us. I am the moderator, but I'll also be supported by as co-moderators by Dr. Anna Mbene, Dr. Christian Dimala, who are of my colleagues, the Cameroon doctors in the UK, CamDocUK. This moderation team will be backed up by a technical team of experts who are Dr. Moncho Morgan, who is the membership secretary of CamDoc. I should have pointed out that Dr. Anna Mbene is also the social and communication secretary, while Dr. Dimala is joining us from the US, and he's in charge of all the technical engineering work at CamDocUK. So Dr. Moncho Morgan is the membership secretary, Dr. Valentine, who is our education lead, who has just done the introduction, who introduced me. And of course, all this team, there's one lady who carries all of us on her shoulders, and that's the chairperson of CamDocUK, who is Dr. Linda Bello. So, welcome to the webinar, the 18th, as Dr. Ngwa said. Today, we're going to look at sickle cell from another perspective. Sickle cell is a very challenging condition. Suffice to say that it's a very serious blood genetic disorder that with the appropriate knowledge can be very well managed. In fact, presently, there is a potential, there is a cure, although because of the cost involved in it, people are still living the challenges of sickle cell. Well, with appropriate knowledge, people with sickle cell are living already to normal life expectancy, especially in Europe and the US. But of course, in other parts of the world, people are struggling a lot. And even more so on the other aspects of sickle cell, which we're going to focus on today. So today we'll be talking about the mental well-being of people who are living with sickle cell. And the three experts we've got for the panel today. We're going to have someone who give us the factual information on sickle cell disease, and that is Dr. Lola Oni, OBE, Order of the British Empire, for those who don't understand how the use of that expression. Marie-Claire Kofi is going to present the user engagement perspective, because when you're developing whatever in terms of policy and treatment, it's important that the user perspective actually shapes that. Marie-Claire is going to come from that perspective, or the user's perspective. And then she runs an organization called Plasma of Hope. That's the framework that she uses. And we are focusing today on the mental health side of things. And there is no better expert than my own colleague at CamDocUK, Dr. Humphrey Enow. I'll introduce them a little bit more as we come to the various bits, but let me start with Dr. Oni. So Dr. Oni will be going first, and Dr. Oni, Lola, I keep saying Dr. Oni, but Lola and myself go back over 30 years of the sickle cell campaigning. When I left the Royal Marsden, for those who may not know, I lost my own son to sickle cell disease in 2002 here in London. And that was when I switched away from nuclear medicine at the Royal Marsden to join Lola and the team on campaigning on sickle cell issues. And they took me under their wings. I learned a lot from them. So Dr. Lola Oni is a consultant, lecturer, and a former nurse director at the Central Middlesex Hospital. That team at Central Middlesex Hospital is credited with effectively orchestrating the mainstreaming of sickle cell issues in the UK. Prior to 1979, a lot of sickle cell issues were in the margin, but they brought it from there to the mainstream. And it's no surprise that within their team, Lola's colleague actually became the chief medical officer in the NHS for Professor Sally Davis, who may not know. But then this is because the pillar behind all the work that they were doing down to Dr. Lola Oni. So Dr. Lola Oni is going to give us the facts, the factual information on sickle cell disease. So Lola, you've got the microphone.
Dr. Loney, please unmute yourself.
Sorry, can you all hear me? Sorry, this thing's gone back to the very beginning again, to the very end. And I don't know why, but anyway.
Dr. Lola, if you could just stop sharing and then share again, and then you'll be able to.
I may have to. Yeah, I may have to. I did put it to the beginning, but for some reason it's gone back down to despite doing the trial run. What a disappointment.
It's so good.
Yeah, I'll just Sorry about this. For some reason, slides have frozen and decided not to play.
Dr. Lola, would you like us to share it for you?
I'm not sure if you've got it, have you? I'm just trying to.
Okay.
I'm just trying to. For some reason, it has frozen and decided it's not playing ball.
If you need to unmute yourself, Chief.
Yes, it's not. For some reason,
So I was saying that while they're sorting out the technical issues with Lola's slides, I wanted to say that the Sickle Cell Society was actually born from within their team at the Central Middlesex Hospital. The Sickle Cell, that was in 1979. And that's the team that is credited with bringing the sickle from where it was into the mainstream in the UK NHS. And from the UK, it went on to Europe and the WHO and globally. So we're talking about standards in children, treating children, adults, and a lot of these things were developed within their team. Lola was actually heading the group, the clinical group at the Central Middlesex Hospital up until recently when she decided to take a well-deserved break. Are we ready to go? So, and that is part of the, that was part of the University of London, the Imperial College of the University of London. That was a team that was based at the Central Middlesex Hospital. When I joined them in the Royal Marsden Hospital, I just left nuclear medicine to join, as I explained earlier, for those who were in personal experience, losing my own son, and I was persuaded by that team to become the chief executive of the Sickle Cell Society. So I was learning advocacy, learning about orchestrating engagement, learning the whole issue about mobilizing various multidisciplinary teams. I was learning from them. So I'm sure when the slides are sorted out, you're going to be impressed with what Lola is going to be saying this afternoon, this late afternoon from London. I say afternoon from London because it's 6 p.m. Well, it's gone 6:25 now. Those of you in other parts of the world, some of the, I think those in the US might still be early morning now.
Sorry, can you hear me?
Yes, we can hear you, Lola. Are
Okay.
Are you ready to go?
Yeah, I don't know why it decided to freeze, but I am trying to get it back, and it was working when we did the trial run. So
It was perfect.
sincere apologies. Can you see my slides though?
You haven't shared them yet, so share your screen.
Okay, I'll go back to sharing my slides. Read this.
So we'll be looking at, as working on Lola while they're sorting out the slides. We need to start from today is we're going to focus on the mental well-being, but we need to start from, give some factual lowdown. That's what Lola is going to be working on. And then after that, we're going to look at essentially the advocacy side. The surrogate advocacy is a vital issue. And
I'm going to try again. And hope that it will go back to the beginning. It keeps going to the end of the slides, but I will.
So that's perfect. You go right to the top as you're doing.
Can you see my slides now?
yes, we can see it. Go right to the top. Keep
right
scrolling back.
Yeah, I'm trying to get to the top now, so hopefully
back up. Keep going.
It'll keep going to the top. For some reason, it seems to. Okay.
Yeah.
Right.
There we are. We're ready to go.
Oh, what's happened here again? Nope, it seems to be having problems going to the sharing.
Perfect.
Can you see my slides?
Yes, we can.
Yeah, but it doesn't seem to do it as a slideshow, but I will continue as I am. Oh dear, no, it's done it again.
Okay, Dr. Lola, if you could
Yeah.
just send if you can just send the slides to us and we'll share. But you can start the presentation with it off slide mode. But before you start,
I'll just have to do it off slide mode and we'll continue as we are, if that's okay. Can you all see the slides?
Yes.
Okay.
We can
Okay,
just carry on.
That's fine. We'll just carry on as we are.
Yeah, just carry on.
At least, yeah, otherwise we'll lose a lot of time. So apologies for that. Technology is not always how you want it to be, but hopefully we'll be able to move on and take things forward the way, we've got it at the moment. Okay, so my talk is what is sickle cell disease. I want to start by explaining that quite a number of people feel that the word disease, they prefer the word disorder as opposed to disease. But the reason why we as professionals prefer the word disease is that most of the literature and most of the information you'll find globally describe the condition as disease. And some people have traveled to other countries and say that they've got sickle cell disorder, and people believe that they haven't got the actual condition, or they've got something that's much milder. And that makes it very difficult for them to get adequate and proper care. So as a result of that, we, particularly us as professionals, prefer to adhere to the word disease so as not to cause confusion globally. So sickle cell disease is a condition that affects the oxygen-carrying red blood cells. And red blood cells.
Sorry, Dr. Lola, just 1 second. For those
Yeah.
who, just to alert people that a point of order here, that some people might want to use captions, subtitles. If you go to the bottom of your screen, you should be able to follow through using subtitles. That's just what I wanted to alert people know. Sorry, I didn't say that at the start, but it's very important. Okay, thank you. Carry on, Lola.
Thanks. So it's quite important to recognize that sickle cell disease is not catching. You have to get it from your parents in order for you to have this condition. So it's not catching, it's not contagious. It's not bad blood, because some people believe that, it's that the family has got bad blood. It's non-discriminating, and it's not due to a curse. Many parts of the world, particularly in Africa, people believe, it's a witch that's causing this problem in a family. It's very important to recognize that whatever genes, the same way you inherit the color of your skin or the shape of your nose or how tall or short you are, it's the same way in which you inherit the type of hemoglobin that you have. So when we're talking about sickle cell disease, we're talking about your blood components. So within the blood, there's water, there's platelets. Platelets help you to clot when you cut yourself. There's plasma, which help to carry blood around the body. White cells, which help you to fight infection, and red cells, which carry oxygen around the body. So when we're talking about sickle cell disease, we're talking about the red blood cells. The red blood cells contain a substance called hemoglobin, and it's that hemoglobin that attaches to oxygen and carries it around the body. Now, sickle cell disease, people think, has only been described in Western countries, but sickle cell disease in Africa has been described in many, many, many communities. For example, the Ghanaians have descriptions in their various languages for describing sickle cell disease. So do Nigerians, where I come from. And the Nigerians believe these are children who are born into a family only to die and to return back again just to torment the parents. So they call them Abiku, which means born to die, or Ogbanje, which is what the Igbos call them. So there's lots of myths about sickle cell disease, particularly in Africa. Then when we're talking about groups at highest risk, it's people of non-Northern European origin, and those whose ancestry can be traced to Africa, particularly West Africa. I believe there's somebody here from Gambia. So in Gambia, for example, 1 in 3 people are carriers of the sickle gene. And in Nigeria, 1 in 4. And so different parts of the world, the highest ratio is in West Africa. In the Caribbean, you'll find 1 in 10 people are carriers. Mediterranean, 1 in 12 to 100. You also see it in Asia and the Middle East. So it's got nothing to do with the color, because people always think it only affects people who are Black, and that's not the case. Sickle cell disease relies on the genes. So whatever genes you've inherited is what determines whether you have sickle cell or not. So for example, I always particularly like this slide because it shows you a white family, which is here in England, in Reading, and you see the grandmother who has got sickle cell carrier, sickle cell trait AS, her daughter who's AS, the daughter's husband who's got AA, but they've got 3 children, 1 of them AA, and 2 of them are also carriers. And you can see these children, particularly the little ones at the bottom, are blonde haired. And people will always be surprised that, where did this come from? And a lot of it is to do with migration and intermarriage. Your genes doesn't know anything else other than what you carry, which you pass on to your children. When we're talking about sickle cell disease, we're talking about hemoglobin, as I said earlier on. The normal hemoglobin combination is AA. That means if an individual has inherited normal hemoglobin from their parents, they've inherited A from their mother and A from their father. But the common carriers that we see is sickle cell carriers or sickle cell trait. But there are other unusual hemoglobins. In total, there's over 1,500 unusual hemoglobins. Sickle is just one of them, but not all of them cause disease. But more commonly, when they're inherited with sickle, then they can give rise to issues and problems. So the most common ones you see globally is hemoglobin AC, beta thalassemia, hemoglobin D, and hemoglobin E. Where you've got both parents are carriers, both parents have AS, for example, then there's a 1 in 4 chance their child could inherit the normal combination AA, a 2 in 4 chance their child could inherit a carrier like themselves, and a 1 in 4 chance their child could inherit SS. This is with each and every pregnancy. It doesn't mean they're going to have one child with AA2. No, it means every time they are expecting a child, this couple, it's a bit like throwing a dice. You don't know what number you're going to get. So that's what happens with sickle cell carriers. The number of people in the UK is about 240,000 with carriers and about 15,000 with the sickle cell disease. In total, there's about 4.4 million people with sickle cell disease globally, and about 43 million who are carriers. I mean, in the UK, in England, we have about 1 in 2,000 births have sickle cell disease. The top 5 types of sickle cell disease are the most common, which is also often the most serious, is HBSS, which is sickle cell anemia, HBSC, sickle hemoglobin C disease, sickle beta thalassemia, sickle hemoglobin D disease, and sickle hemoglobin E disease. These are the most common types of sickle cell disease that you will see globally. So what's the problem? Well, if you look at this slide, you'll see on the right-hand side, the red blood cells of a normal red blood cell are round and soft and spongy, and they carry oxygen very well. They can travel through the blood vessels and carry oxygen from the lungs to the body tissues. But when somebody's got sickle cell disease, when these red blood cells give up their oxygen, they change into abnormal shapes, like the farming tool called a sickle. They can be any odd shape, but they become very hard, very brittle. They can't carry oxygen very well. And the problem with them is that they can get stuck in the small blood vessels. When this happens, the red blood cells can't allow the blood to flow. And if the blood doesn't flow, you get pain in that part of the body. And that's what we call a sickle cell crisis. These abnormal cells blocking blood flow to that part of the body. And it can happen in any part of the body. What is the main issue with sickle cell disease? The main issue is pain as a result of these blockages. So we call it a vaso-occlusive crisis. Individuals with sickle cell disease from a very young age, the spleen, which normally helps you to make, to protect you and make immunoglobulins and protect you from infection, the spleen gets very damaged from very early on. So the immunity is very poor as a result of having sickle cell disease. And that can then create a problem for managing, infection and so forth. But like I said, the main issue with sickle cell disease, or the hallmark of sickle cell disease, is sickle cell crisis pain. And the pain can be from mild, moderate to severe. And some people will tell you it's as severe as childbirth pain. Or for the men will say it's almost like somebody kicking you in the groin repeatedly. It can be very, very painful. And others have described it as similar to the chest pain that you get in heart attack. So it can be a very excruciating pain. We find that majority of vaso-occlusive sickle cell pain is managed in the community because some people assume that if you have sickle cell crisis or you're in pain, you're always in hospital. That is not so. 10% of the total patient population here in the UK account for 90% of hospital admissions. So that tells us that it's those who are more severely affected or their disease is more severe that tend to go to hospital a lot more. And at the same time, 90% of those who come into hospital is as a result of vaso-occlusive pain crisis. Other things can cause people to come into hospital with sickle cell disease, like infection and things like that. But vaso-occlusion is the most common cause that causes people to come into hospital. But there are many things that people can do to prevent ill health with their sickle cell. And there are many, we educate people about what are the things that can trigger sickle cell crisis. For example, not eating properly, not having the right nutrition. Being dehydrated is one of the main common cause of sickle cell crisis. If the blood hasn't got enough fluid in it, and individuals, the red blood cells will more likely gather together and cause an obstruction. So they need to make sure they drink lots and lots of fluid and water all the time. They need to avoid extremes of cold and heat, because when you're cold, your blood vessels get narrowed, and therefore these cells are more likely to jam up. If you're hot, then you lose fluid, which means you'll get dehydration. We also tell them to avoid strenuous exercise, because the more you exercise, the more you need oxygen. The more oxygen you need, the more stress it puts on those red blood cells. And we give people with sickle cell disease prophylactic antibiotics, which they take daily. So they must maintain that to help them fight and prevent infection. And the most important things is making sure they're aware of their own condition, how it affects them as an individual, and stick to the treatment as given by their doctor or suggested by their doctor. It's important to manage individuals with sickle cell disease by educating the parents, the family, and the patient themselves. From a very young age, we make sure that individuals are well educated about their condition. They must attend their outpatient appointments, because by monitoring how their disease is affecting them, we can prevent some of the complications that then arise in adulthood. We manage their pain when they come in with acute pain, and if they've got chronic pain, when we look for ways in which that can be managed appropriately. And they come into hospital when the pain can't be managed at home, or when they're unwell and it's nothing to do with pain. Because we have to remember, people with sickle cell disease also have any ailment that anyone else can have. They can have appendicitis, they can have cancers, they can have anything that anybody else has. So we need to manage them and monitor them regularly. And of course, the social and psychological support is a crucial part of preventing mental health in this population. Having said that, we have to remember most people with sickle cell disease manage their condition very well, are well supported by their family and community, and therefore the social and psychological support that they need is provided, and they're able to maintain their health and their well-being. So what are the issues that can affect mental health of people with sickle cell disease? If we start with the childhood, you can imagine that, every time you're having a crisis, or every time you have to attend outpatient appointments, you're having to keep having time off school, or every time you're ill and you're in hospital as an inpatient, it means that individuals lose out on small amounts of schooling over the years that they spend in school. A lot of these children feel that they're very different to their peers. They're unable to engage in certain activities that their peers engage in, because many of my children, for example, when they go swimming, they end up having a crisis because they get cold. They can't indulge in certain fashions, unlike their friends, by being exposed to the cold and things like that. Going camping with school can be a problem. So there are different things that can make it difficult for them to cope with living on a day-to-day basis. People with sickle cell disease, because they're anemic, not because they're iron deficient, but because their red blood cells don't live as long as the red blood cells of people who haven't got sickle cell disease. So they get very fatigued. If we say the normal hemoglobin level is 12, people with sickle cell disease may have a hemoglobin level of 6 or 7. And that's why they get very tired and they get very fatigued easily. And these children can lose concentration in class because they get very sleepy and tired. And then you talk about self-body image. Delayed growth is very common, but because we manage these individuals very well, we're seeing less and less of those issues in our patient population. But we're well aware that in some parts of the world, this is still a major problem. Some children have jaundice because the red blood cells are being broken down very rapidly. They can get yellowing of the eyes and the skin, and therefore that makes them conscious that they're different to their peers. So they can experience delay in education. And as I said again, and I keep repeating, social support is crucial for this patient population. By the time you get to teenage and young adulthood, evidently, there are some complications that are associated with sickle cell disease that can make you feel that, you are very different. Some teenagers, unfortunately, have leg ulcers as a result of their sickle cell disease. Delayed growth, compared to your peers, you're maybe shorter and smaller, and people don't necessarily give you the respect you need, you're entitled to when you're that age, because they assume that you're much younger. And of course, they can't afford to take part in some of the risky behaviors that a lot of their peers take part in, like smoking and drinking alcohol, because all those things can exacerbate and make their condition much worse. Self-perception, perception of self, and development of social skills, and the realization that this is a lifelong condition can cause despair in this population. The biggest challenge that a lot of people have, particularly in developing countries, is the stigma. The stigma associated with, you know, being somebody with sickle cell disease, or the family can get stigmatized, the experiences they have within the healthcare system. And a lot of our patients find they're well looked after and cared for, and people are sympathetic when you're a child. But by the time you get to a teenager and adulthood, you know, the healthcare professionals may not be as empathetic and sympathetic as they should be. And that can cause a lot of despair. And then, of course, you start thinking about relationships. At what point do you tell somebody you've got sickle cell disease? And how is it going to affect your family dynamics? Even siblings experience being stigmatized as a result of having a family member with sickle cell disease. And friendships and courtships can prove a difficult period for people with this condition. So delay to education can make it difficult to attain life goals. What employment can you aspire to? What sort of problems will you experience when you start work? And this leads us into the adulthood issues. So by the time you reach adulthood, then you're grappling with issues to do with, you know, frequent hospitalizations and the disruptions to life, building a long-term relationship, you know, the physical appearance of being a smaller stature, or having problems like leg ulcers or hip problems that have caused your hips, you know, to make you start to limp or walk differently. And then education and career progression. How well can you manage that? And what are the opportunities for you? And of course, you start getting to the realm of employment, type of employment you can have, how you're going to be able to maintain yourself as an adult, your finances, being able to access things like house insurance, health insurance, makes it much more difficult. And as I said, society's attitude and stigma persists right through into adulthood as well, and relationship with healthcare professionals and others. But the social psychological support remains essential. Those who are able to cope well with their sickle cell disease are the ones that have had that social psychological support from childhood into adulthood. The ones that find it difficult or have not had that tend to find it unable to be resilient and able to cope and adapt within the world environment with their sickle cell disease. I've put a few useful links here, and thank you for listening. And apologies again for the difficulty of getting the slides loaded. Thank you.
Wonderful, Dr. Oni. As usual, very engaging presentation, this time on the factual realities of sickle cell. There are quite a few questions coming through, a lot of questions coming through in the Q&A section. I'll just urge everyone to keep sending your questions through, because the panel, they've all agreed to stay at the end of their presentation so that we can then have a full house of proper engagement. But there are, just for now, Dr. Oni, one linked question is this one about the use of antibiotics. I know we're here to talk about mental health, but I thought we should just get that one out of the way. The challenge of prophylaxis versus antibiotic resistance. Someone is asking to know will that putting them on this prophylaxis, does that not create a risk of antibiotic resistance?
Antibiotic resistance is something that has been reported, particularly in the United States. We have not seen that so much in the UK, but this is something that, you know, when we weigh it up against the benefits of the prophylactic penicillin, all this is based on extensive research that shows that prophylactic penicillin saves more lives than cause harm. If somebody has developed resistance to a particular antibiotic, they can be given another type of antibiotic, because the benefit of it far outweighs the limitations of it. And that's why, you know, you'll find that globally, prophylactic antibiotics is still a very important provision for people with sickle cell disease of any type.
Thank you so much. Well, I hope the person who asked that question is finding some of the answers to give back. Very interesting. I know that Array Echi is asking a question about keeping a job. Let's put that when we come to the proper panel discussion at the end of this presentation. But for now, just one more further question, which is a really burning issue relating to the factual information that you gave earlier. Someone who would like to know the difference between SC and SS in terms of severity.
Generally, SS is often more severe than SC, but for me, the issue is often, as after almost 40 years in the field, those with SS are more likely to have more crises. Those with SC, they're often milder, but that doesn't necessarily always follow. Some people with SC can be just as severely affected as clinically as somebody with SS. But the problem for me with people with SC is that sometimes they themselves and their families can get quite complacent because they don't get as many frequent crises as somebody with SS. And therefore, when they do have ill health or problems, it can be missed or it can be ignored because their family or they themselves are not used to being so unwell. And so for me, I say any type of sickle cell disease is serious and should be considered as serious, irrespective of whether it's SS or SC. But generally speaking, people with SS have more complications or more clinical severity than those with SC.
Wonderful. The questions just keep pouring, but I'll plead with the audience to just bear with us. Let's go through the presentations, and then we can come and we have a full house where we can, the panel will then take some of the range of questions, because they're just flooding in the questions. Now, let's move on to the next speaker. It is always, we've now got the factual information. Thank you, Dr. Oni, OBE, Fellow of the Royal College of Nursing. Thank you very much for that engaging start. We now look at the next stage, because as Lola was saying, sickle starts from it's a medical, but then it then creates all sorts of challenges, which psychosocial, as Lola herself stated. It brings therefore the need to, it's important that we involve those who are affected by the condition in the way services are actually developed. The language in the UK, like I assume at the WHO, is that we make sure that services are actually responsive. Are we meeting the needs of the people who are living with the condition? Are we addressing those issues that are important for them? And there is, this is where the next speaker comes in. Marie-Claire Kofi has been involved in this side of the thing, in not only the UK, but only recently she just came back from the European Parliament in Strasbourg, where they were looking at essentially how to orchestrate the way users are involved, in the way policies are developed, in the way support is being generated for service users. We keep talking about Europe, but we know that these are things that can be extrapolated to Africa. So we just want to reassure our friends watching from other parts of the world that here are potential linkages that are going to come. But let me just get Marie-Claire to then do the next presentation. So Marie-Claire is a scientist, is a radiographer, who is also a mom of two, and I know very supportive partner in Clyde, because I worked with them over the years. When I was chief executive, I had my lieutenant, and Marie-Claire was one of them. So Marie-Claire, please, you've got the microphone.
Thank you. That was such an honorable introduction. First of all, thank you to Dr. Lola for such an insightful and very educative presentation on sickle cell disease. And I must say it's such an honor to be presenting here and sharing my experience to people across the globe. We have people from Africa, you know, a lot of people here do live with sickle cell disease. So I will be speaking from experience, which I am sure most of you are going through, and from what I have seen in the chats as well. So just you've heard the introduction about me. So just to tell you a bit further, I currently live in the UK, but growing up, I wasn't so privileged. I had a very difficult childhood. So I was born with sickle cell disease. I come from a family of 6, and 2 of us had sickle cell, my brother and I. And I grew up very angry, very different, because I was made to feel different. I always used to ask myself why I was so different, why I had this disease, why I was given sickle cell. I mean, I didn't understand the genetics or the biology of sickle cell disease. I just knew that I was very different. I was always in pain. My family was always suffering as a result of me going through the challenges of sickle cell. I was constantly in hospital, either with a pain crisis or having a blood transfusion from various people in the community. And I was feeling very isolated as a young girl, and more so because the people around me made me feel different. I remember many a times my mom would sit and get really upset and cry and ask why was she giving this burden. And I'm sure most of you have heard this, your parents will say they would rather have the disease than to see a child go through it. Many a times I knew that, you know, some of the worst crises that I've had, that will be the last. Growing up in Cameroon, I'm originally from Cameroon, I was told that because of sickle cell disease, I wasn't going to live past the age of 7. And I had no reason not to believe that, because a lot of my peers that had sickle cell disease died at a very young age. And even today, the statistics are showing that children with sickle cell disease are even dying before the age of 5. So I was told that I was going to die by the age of 7. Come 7 years old, I didn't die. And I was wondering why. But I was very sick, so I knew that at some point, this is going to be it. And I went past 7. I was told that I wouldn't make it past 21. And these are the people that I looked up to, my family, my community. It's because of the perception and the stigma that had been associated with sickle cell. So I lived without having any aspiration of wanting to be anything. I struggled quite a lot in school. I was very tired. I was very jaundiced. As you can see from Dr. Lola's presentation, people with sickle cell have very yellow eyes. We show very yellow eyes. And I was called all kinds of names. I remember quite vividly, I had a nickname that stuck with me for a very long time. Almost everyone in my community was calling me Sicky or Sickling. And a lot of people didn't even know my name. They just said, you know, that girl that is always sick. Sometimes people will not even invite me to parties for fear that I will get into a crisis, because that had happened quite a few times. I remember one time when I was in primary school, this has stayed with me for as long as I can remember. My mom wasn't able to pick me up from school, so she had asked one of her friends to pick me up from school. For those who are from Cameroon, and some of my peers are here that we went to school together, it's such a pleasure to see you all. I went to CBC school and I was very sick, and my teachers were literally so fed up with me. My mom asked her friend to pick me up from school, and she did. When we got home, I was very hungry. I asked her that I wanted to eat, and she refused to put food for me in a plate. And she said to me that she doesn't want her children to catch sickle cell disease. That broke my heart. And from that day onwards, I kept questioning why I was even born, because nobody wanted me around them. I barely had any friends. People were afraid to hang around me for fear that I was going to be sick, what's going to happen, or, you know, she shouldn't come and die in our hands, in our compound. So I was very different, but I didn't understand the reason for that. I did not understand the mental health implications. You know, as a young girl, and most people in Africa, we know very little about mental health conditions. But I knew that I wasn't happy. But the one thing that kept me going was the support and the love that I had from my family. And when I say my family, I mean my mom, my dad, my brothers, and my sisters, because they were the only people that gave me hope to keep going. I repeated so many times in school. I failed so many exams, and people just knew that, oh, my teachers especially, they just could not put any effort in me. So I was always behind. I got to my teenage years. All my friends were developing and having breasts and becoming beautiful women. But I realized that, and it's only when I became aware of some of the implications of sickle cell, I realized that I wasn't developing as the same as my peers. I wanted to wear a bra, but I didn't have any breast. I didn't have my periods. I went to a boarding school. You can only imagine what that must have felt like. I was in Form 5. I barely knew anything about periods. I went to high school. And it's only later that I realized that due to me having sickle cell, my growth was being delayed. And a lot of people made mockery of me because of that. These are some of the things that a lot of us go through, but we can't talk about it. But I traveled to the UK in my early teenage years. And when I came to the UK, I saw a very different side of sickle cell. All the stigmatization that I had faced in Cameroon were different. People had a different perspective of sickle cell disease. And I wanted to understand why. I was very sick when I traveled to the UK, and I was scared to go to the hospital for fear that people are going to say all sorts of things. When I was in Cameroon, every time I went to the hospital with my mom, the nurses would say some horrible things to my mother. And it so happened that my mom also used to work at the General Hospital in Boya. And you will hear terrible things from her colleagues. People would send me and my mother to places that I only cannot begin to think of. We traveled far and wide. I remember one time we went to a village in Nkwa, somewhere. My mom was told that there is a man that can treat sickle cell disease. And my mom and I traveled for so many days. And by the time we got there, I had gone into a crisis. And when we got to this place, I was giving a horrible treatment, beaten with so many leaves, because they were trying to get sickle cell out of me. And my mom could not go through that anymore. In the UK, I saw a different life. I felt like I had a purpose. And I know I am privileged to say this because a lot of people in Africa are not privileged to have the care and support that they need as people living with sickle cell disease. But like I said, the only thing that kept me going was the support and care that I received from my family. And for all those people here on this webinar today, what I can tell you is, with the right support and right understanding of sickle cell disease, you can give your loved ones a better quality of life. I could have given up. Unfortunately, my brother died at the age of 32 due to a very bad sickle cell crisis. But there was one thing: we were loved. So if there's anything we can do to show some support to people that live with sickle cell, is to have a little bit of compassion and understanding of what folks with sickle cell disease are going through. I have had so many relationship breakdowns. People are scared that I am going to die in the midst of an intercourse, in the midst of childbirth. I have had so many people refuse their family not getting married to me because I have sickle cell disease. The mental health implications are so many that you can't even begin to put that in a book. Sickle cell disease is something that affects our community, but we are so shy away from talking about it. But I know that if we don't talk about it, we will not support each other. I have been able to become comfortable to talk about some of the challenges that I have faced living with sickle cell disease. And I am proud to say that I have given so many people the courage and the voice to come out and share their experiences. we did not choose to be born with sickle cell disease. So these people should not be shun away from our community, because if we understand what sickle cell disease is and how to support them, we will have a better community and support each other with love. Thank you. I will share, in the end, I will share a slide of, if you want to get in contact with me or CamDoc, I will share my slide of the organization that I represent. And God bless you all. Thank you.
Wow. Marie, another sterling intervention. Wonderful. As you can imagine, just like when Dr. Oni spoke, there are questions flooding the screen, but I'll again ask people to just bear with us, because we'll address the panelists have agreed to stay on after the presentation so that we can actually have a full house. But two burning issues, questions, Marie, coming through, which I hope you will just give a brief intervention so that we can move on to the next speaker. The first question they ask is, especially given your experiences growing up in school in Cameroon. So a professor in Yaoundé, Professor Keng, is asking, what advice would you give to the school administration to be able to address mental health issues, some of those challenges for the school learners? You can imagine a professor in Yaoundé looking at what lessons you can actually advise them. That tells the impact that you're having.
Yeah, thank you. I'm quite pleased that that question is coming from Cameroon. So what growing up as a child, and from the feedback I'm getting from people living with sickle cell disease currently in school, is that the school has very little knowledge of sickle cell. And I think what can be done is that for people like Professor Keng, I think what the school can do is to find educational materials, to send some of the teachers to some educational sessions so that they are aware of some of the mental health challenges that some of these children, some of these people live with in school, so that they have a better understanding of supporting them. Because what tends to happen is that someone cannot help you if they don't know how to help you. So if they understand how sickle cell affects people mentally, they can support them way better, especially in education.
Wonderful. And just to add perhaps that given that, as Dr. Oni said earlier, it's the commonest human blood genetic disorder. So I can imagine this is something that those designing curriculums in schools can think about, at the very least try and see how they can maybe at some point some lectures at school, maybe once a month, a term or something, on some of these key challenges that their learners are actually going through, and sickle cell, why not, should be one of them. And the second question, which I know we push for time so that I can go on to the next speaker. This one is really directly personal, perhaps by fault, because I mentioned the fact that you're such an amazing inspiration, that you're actually having two young boys, two children. So they were asking, the question came from an anonymous person. Could you explain, how do you actually explain sickle cell to those here, to the children?
Yeah, right. That's interesting, because it is important that our children know what sickle cell is and understand it, because they hear me talk about it a lot of the times. So what I do is I explain it in such a way that they, as children, we have a better understanding. I have a board in my bedroom where I have drawn. I have two boys, 7 and 3. So the 3 it would have very little understanding of sickle cell, but my 7-year-old Jason, he has a very good understanding. So I have drawn a board, just something similar to what Dr. Lola presented, but in a very child-friendly manner. I have explained to them the red blood cell, and I have drawn human beings on the side, and I have put on those drawings a normal red blood cell and an abnormal red blood cell. And of course, he's 7, he knows a little bit about oxygen. So that's how far I've gone. I've just said to them that this is how mommy's blood is. Because my blood is squiggly, I don't have enough oxygen, because they have seen me go into crisis quite a lot of times. So they understand that mommy's blood does not have enough oxygen going through. So that means mommy can get into pain sometimes, maybe when she's stressed. So we'll try not to stress mommy. So they have a basic understanding. And this is a very important question, because it is very crucial that we educate our children about sickle cell disease, because this stigma that we are trying to eradicate, we can only do that by educating the young people to have an understanding of sickle cell, so that they see that it is normal for a human being to live with sickle cell without being stigmatized. So thank you for that question.
And wonderful, wonderful. And let me just add to that to say that Dr. Oni and the Sickle Cell Society, they have developed a lot of resources which CamDocUK, at the end of this presentation, when we are loading on our CamDocUK website, will create linkages where people can actually use to access free resources that will address this kind of issues about how young children can understand what sickle cell. Some of the things to support you, the parents and uncles and aunties out there, on how to talk about sickle to young children. And Lola and her team had developed quite a lot on the Sickle Cell Society. And of course, Marie's organization called Plasma of Hope. So we will, with their permission, we'll make sure that these things are all linked up to a signpost to this, at the Sickle Cell, at the CamDocUK website. Now, we have been looking at—
Dr. Asa'ah, sorry.
Yes,
Can I just say, just responding to that first question quickly, if you want to get in touch with me, we have some partnership with schools in Boya where we're providing education for sickle cell. So CamDoc will have all our details. If you want to get in touch, please follow suit. Thank
Excellent.
you.
Just to say that we've been focusing largely on clinical issues. We have actually addressed, and I started by saying earlier on when Dr. Oni spoke, was that sickle is a very serious issue, a medical condition, but with appropriate medical knowledge and the expertise, like we've had the subject matter expert too so far spoken, with this sort of level of support, the condition can be well managed. In fact, the clinical side, there is already a cure, in as much as not accessible because of the cost. Now, but today, we are also therefore benefiting from this expertise to explain also now the mental side, how to live, how to achieve well-being, mental well-being in sickle cell disease, when you're living with sickle cell. We spoke about the clinical side, we spoke about the factual issues. Marie has given us essentially the challenges that you need in terms of addressing personal, the impact on the person, the impact on the family, the impact on the community. That's what Marie was saying, and how Organization Plasma of Hope is there to provide that level of advocacy and support, so that you can influence the support for the family, as well as the way government policies, here already school policies being addressed when the professor spoke. We are now moving on to also now to get the factual information as to how we can actually address well-being in sickle cell disease. And this is where I bring in my colleague of CamDocUK, one of the original members of Cameroonian doctors in the UK, Dr. Humphrey Enow. He is a consultant in a consultant psychiatrist at Northamptonshire National Health Service Foundation Trust in the UK. And he's going to address essentially the bring us now the expertise from the underlying the whole mental challenges that we've been hearing from Marie and others. So, Dr. Humphrey Enow, you've got a microphone. Thank you very much for offering to share your expertise.
Thank you, Chief, for the introduction, and good evening, everyone. And thanks for opting to spend your Saturday evening with us. Over the next 30 minutes or thereabout, I will be discussing sickle cell disease and mental health. My presentation will highlight the current research between sickle cell disease and some common mental health conditions. I'll also explain how some of the psychosocial issues that Lola raised in her presentation affect the mental health of people living with sickle cell disease. Before I go into my presentation proper, I would like to just thank Marie for what I thought was a rather impassioned presentation, and to congratulate her for the work she does in sickle cell advocacy. Marie raised a series of pertinent issues in her presentation, which I'm going to try and see if I could correlate or connect with the theme of this webinar, which is how do we safeguard the well-being of people living with sickle cell disease, and by extension, the well-being of your family members. As you heard from Marie's presentation, our family has been her rock. So how do we safeguard the well-being of family members and caregivers looking after people with sickle cell disease? If you listen to Marie's presentation as intently as I did, it should be very obvious to you that as a community, we are actually failing those who are living with sickle cell disease. What if I put it to you guys that whatever you do to improve the quality of life of someone with sickle cell disease will invariably enhance their mental well-being? So whatever you do to improve the quality of life of anyone with sickle cell disease will invariably enhance their mental well-being. The phrase mental well-being has been trending for many years now. There are plenty of well-being experts, wellness experts, plenty of well-being websites and wellness experts out there. But what does well-being mean to you? How do you relate to it? Some people actually confuse the concepts of mental well-being and mental health. Mental health and mental well-being are two concepts that are very close together, and oftentimes they are used interchangeably. But there is a subtle difference on where the emphasis is placed within each of these respective concepts. So mental health focuses primarily on the presence or absence of an underlying mental illness. So the keyword there is primarily. I work as a mental health consultant, and my primary focus when someone walks into my clinic is on whether or not they have an underlying mental illness. Of course, I'm interested in their happiness, but that is not my primary focus. Mental well-being, on the other hand, will focus primarily on your happiness and how satisfied you are with your life. So you can see well-being is not some abstract construct. It is simply a measure of how you feel about yourself and about your life. If you feel good about yourself and about your life, you have a good mental well-being. I actually took some notes when Marie was speaking and tried to come up with a few examples of how to make the concept of mental well-being as relatable as possible to you guys listening to me, and I'll just read through them. So again, remember, anything you do to make someone with sickle cell disease happy enhances their mental well-being. So if you work as a receptionist in a hospital who looks after patients with sickle cell disease, or you work as a staff, if you can show some empathy and compassion, they turn up, that would enhance their mental well-being. If you live close by to someone with sickle cell disease, if you check on them frequently and offer to help with school runs or childcare or grocery shopping when they're struggling to, that would enhance their mental well-being. Again, anything you do to make them happy will enhance their mental well-being. If you're a friend, create the space and time for them to share their thoughts and feelings with you, for them to share their fears, their worries, anxieties with you. And if you think they're struggling, encourage them to get professional help. And if there is anyone listening who is in a position of authority or power, who can pull some strings, you go ahead and pull those strings so that we can have increased funding into sickle cell research and sickle cell resources. And to the community, I think we should all reflect on why there is still a lot of misconceptions and mistaken beliefs within the communities around sickle cell disease, despite the amount of knowledge that is available out there for us all. And it is these misconceptions that fuels the negative attitudes and stigma and discrimination that is still prevalent within our communities towards people with sickle cell disease. And if we can get rid of these negative attitudes, I can assure you all that, this will have a profound effect on the well-being of people living with sickle cell disease. We're going to move away from well-being now and talk about mental health. Like I said earlier on, well-being focuses about happiness and how satisfied you are with your life, whereas mental health focuses on the presence or absence of an underlying mental illness. This is what we're going to cover in the next. Can you see my slides?
Yes, we can.
Okay. I'm having issues sharing. Okay, this is what we're going to cover over the next, let's see if I could do it under 10 minutes. So we're going to discuss the current research evidence between sickle cell disease and depression and anxiety, current research evidence between sickle cell disease and suicidal ideation, current research evidence between sickle cell disease and psychosis, current research evidence between sickle cell disease and cognitive deficit, current research evidence between sickle cell disease and substance abuse. Dr. Lola in her presentation briefly mentioned some psychosocial issues that people with sickle cell disease put up with. I'm going to see if I could try and explain how that could increase their risk of coming down with either any of the common mental health conditions that they may be genetically predisposed. We know that depression is commoner in people with sickle cell disease compared to those who do not have sickle cell disease. So 1 in 3 people with sickle cell disease will have at least one depressive episode in their lifetime. This is compared to 1 in 4 among those who do not have sickle cell disease. And we also know from current research that oftentimes people with sickle cell disease who have depression will go undiagnosed and untreated. And the reason for this is because there seems to be a huge overlap between depressive symptoms and some of the symptoms that we tend to see in sickle cell complications. So things like fatigue, reduced sleep, low mood, lack of appetite, lack of motivation can straddle depression and sickle cell disease. And what tends to happen is that clinicians are more inclined to attribute these symptoms to your sickle cell complication, rather than taking a step back to explore if there is actually a depressive episode occurring alongside your sickle cell disease, which is the case. And this is very important because if there is a delay, if you have depression and there's a delay in treating that depression, whenever treatment is commenced, it is very likely that you may not respond as effective as if the treatment was commenced at a very early stage. I just realized I went into depression without explaining what it is. So depression is simply when you have persistent low mood, say every day for more than 2 weeks, and if the low mood is to an extent that it can stop you from doing the things that you would normally do. So persistent low mood for more than 2 weeks that interferes with your quality of life. And one of the very important features of depression is inability to experience pleasure. So when you become depressed, activities that used to bring you so much joy will cease to elicit any joy or any pleasure. So if you're someone who used to really get a thrill from golf, for example, if you become depressed, golf becomes ordinary to you and you don't get any excitement from it. So if you know someone who has got low mood persistently, who doesn't seem to enjoy the things that they used to enjoy, it is very likely they're depressed. We're also going to look at the relationship between sickle cell disease and anxiety. Anxiety, as we know, is often connected to depression. And unlike depression, where the predominant symptom is persistent low mood, when people experience anxiety, they tend to, have intense feelings of fear and worry and nervousness. And anxiety, as we know from current evidence, is also more prevalent in sickle cell disease than in the general population. We also know from current evidence that depression can worsen health outcomes in people with sickle cell disease. So in other words, when you have sickle cell disease and depression, the depression can make you have more complications from the sickle cell. So this came from an American study. I think there were about 2,000 participants in the study, and they were grouped into two cohorts. One cohort had depression and sickle cell disease, and the other cohort had sickle cell disease without depression, and they compared their outcomes. And what they found was that those who had depression and sickle cell disease were more likely to get acute chest syndrome, to get vaso-occlusive pain, to be on prophylactic antibiotics, and to have end organ damage. So in other words, those who had depression and sickle cell disease tend to have more sickle cell disease complications. And this finding is very important because it underscores the need for us to be very aggressive when people have depression and sickle cell disease. So that way, we could improve health outcomes and their quality of life. We're going to look at the relationship between sickle cell disease and suicidal ideation. So what is suicidal ideation? So it would range from someone just having occasional or fleeting thoughts about suicide to someone being unusually preoccupied, actively exploring and seeking how to end it all, and anything in between. And we know from current evidence that suicidal ideation is commoner in people with sickle cell disease compared to the general population. So 29% of people with sickle cell disease will indicate at least one episode of suicidal ideation compared to 20% in the general population. We also know that suicidal attempt is commoner in sickle cell disease than the general population. 8% of people with sickle cell disease will indicate at least one suicidal attempt compared to 5% in the general population. What this study doesn't capture is those who engage in self-harming behaviors, which is behaviors that inflict injuries on their bodies without any actual suicidal intent. The next condition we're going to look at is psychosis. So what is the relationship between sickle cell disease and psychosis? I'm pretty sure most of you watching me must have seen or may know someone who was psychotically unwell. Most psychoses have lost contact with reality, and most of them may see or hear things that others cannot see or hear, and refer to as hallucinations, and they could hold on to beliefs that are factually incorrect, refers to as delusions. More often than not, when someone who is psychotically unwell, when they speak, their speech is very disorganized and confused, which is a reflection of their thought process, and it is extremely difficult to follow their train of thought. You don't see them out and about in the UK because they are confined to hospitals and to specialist units, but in Cameroon, you see them roaming the streets, looking disheveled and unkempt. And I'm pleased to report to you that unlike anxiety and depression, which are well-documented complications of sickle cell disease, psychosis as a complication is uncommon. So there is no evidence that sickle cell disease increases your risk of psychosis. We're going to look at the relationship between sickle cell disease and cognitive function, or your cognition. Cognitive function refers to very important brain functions that enable someone to live independently and to succeed and excel in life. And these functions are usually controlled by the frontal part of the brain, also referred to as the frontal lobe. So your cognition includes things like your language skills, things like your memory, your learning skills. Your cognition is what makes you make informed and sensible judgments, what makes you reason things out, what makes you perceive what is happening around you. We know from current research that brain disease can begin very early in people with sickle cell disease and may result in neurocognitive dysfunction. What that means, in other words, is that brain disease can induce, or sickle cell can induce changes within your brain that can make you struggle with any one of these cognitive functions. They could make you struggle with learning, struggle with your judgment skills, struggle with sense of perception, and struggle with memory. The last relationship we're going to look at is between sickle cell disease and substance abuse. The rate of drug abuse in people with sickle cell disease is the same as the general population. It's quite reassuring. And this is in spite of the fact that, as you know, most people with sickle cell disease will take opioid medication, which is an addictive medication, but so far there is no evidence that they get addicted to it. That said, it is still common practice for doctors to withhold opioids from patients with sickle cell disease because of fear of addiction. And it is believed that there is a racial undertone to this. If you look at the data on percentage of adults who abuse substances in the UK, the percentage is highest among Blacks. I think it's 11% for Blacks and 9% for Caucasians, and I think about 4% for Asians. And I can see how this data can influence prescription attitudes. You know, when doctors are invited to prescribe controlled substances to people from Black backgrounds. I'm not justifying what they're doing, but I could see why that hesitancy can exist. So Dr. Lola in her presentation did mention a number of psychosocial issues that people with sickle cell disease mentioned problems with body image. I think she went ahead to say this is of concern to those who are conscious about some of the very recognizable sickle cell disease features. I think Dr. Lola mentioned presence of jaundice and delayed growth. She also mentioned exposure, constant exposure to stigma and misconception. There's also the issue of harassment and bullying that people with sickle cell disease grapple with. There is the effect of frequent interruption and disruption of their routine, which can lead to them being less competitive than their peers, and it could take a toll on their self-esteem and lead to a reduced sense of self-worth. There's also the huge financial cost of looking after someone with sickle cell disease and how it could put a strain on family finances. These psychosocial factors are social and psychological problems that are known to induce tremendous stress on the brain. And whenever the brain becomes overwhelmed with stress, it triggers a series of events within the brain that could increase your risk of coming down with any of the mental health conditions that you're genetically predisposed to. If, for example, you have the genes for depression, and for some reason your brain is overwhelmed by the level of stress that you're going through, then you're very likely to come down with depression. I just want to add that each of these psychosocial factors can induce a significant level of stress to the brain within its own right. So if someone should walk into my clinic and make me aware that they've had prolonged exposure to any of these, I will be very concerned. I'll keep an eye on them. But as you can see, people with sickle cell disease sometimes have to put up with all of these at the same time, which is a huge ask for the brain to deal with. And no surprise, therefore, that as mentioned earlier on, the incidence of depression and anxiety is much higher in people with sickle cell disease. I think someone said pain is a hallmark of sickle cell disease. So I thought I should just put a slide to explain the relationship between pain and mental health. So physical pain and depression have a deeper biological basis than just cause and effect. So this is because pain and depression are influenced by the same chemical changes within the brain. If you look at the brain of someone with chronic pain, the chemical changes that you see within the brain are the same changes that you will see with depression. And this underpins the reason why sometimes we use antidepressant to manage chronic pain. So someone who is having chronic pain, whether it's from sickle cell disease or lupus or rheumatoid arthritis, they're very likely to have a depressive illness because of this deep biological connection. We should also be mindful of the cognitive effect of pain. So when you've got pain, you could get depression because of the biological connection and also because of the cognitive effect of pain. Individuals may find it difficult to participate in social activities and hobbies because of the pain. Could lead to decreased self-esteem and self-isolation. Pain could trigger sleep disturbance, fatigue, and mood changes, and elicit a number of emotional responses that could overwhelm the brain. And last but not the least, I thought I should include a slide on medical prescribing. When prescribing psychotropic medications or psychiatric medications for people with sickle cell disease, we should be mindful of the possibility of drug interaction. For example, if you have someone on tramadol for pain relief, and you want to prescribe an antidepressant for a depressive illness, you should be very mindful that what that could do is could reduce the seizure threshold and increase the risk of seizures. And if you have someone on opioids and you want to prescribe any of the common benzodiazepines, you should be very mindful that it could lead to respiratory distress or respiratory difficulty. These are some UK-based charity websites that you could log onto for more information on support. Thanks for listening.
Chief,
Please
unmute
unmute.
yourself.
Sorry, thank you, Dr. Enow, for a very sterling subject matter expertise that you brought in to conclude the array of speakers. As you can imagine, there's a flood of questions, but let's just take two before we have an open panel. There's a question here about considering how mental health issues are in patients with sickle cell. Should there be a psychiatrist or a psychologist attached to every sickle cell clinic? Very familiar. We have this sort of question every now and again, but there we go. Just bear in mind that this is not just the UK. We're looking at essentially resource-limited settings as well, because we have people from Africa following this. So just so that you think about a wider approach of an audience when you're answering this. So should there be a psychologist or psychiatrist attached to every sickle cell clinic? That's the question that is coming across on the Q&A board.
I think there should be a mental health professional attached to the clinic. That could be a specialist nurse with expertise on sickle cell disease and mental health. It could be a psychologist with special interest in sickle cell disease. Regarding having a psychiatrist in the clinic, I don't think it will be the best use of resources, because if you look at how mental health issues play out, most people with sickle cell disease will fall within the category of mental distress. What that means is that they are emotionally disturbed, it's impacting on their quality of life, but they might not meet the threshold of any of the common mental health illnesses. And as a psychiatrist, my job is, do you meet the threshold of depression? I give you depression and treat depression. You meet the threshold of anxiety? So I think more is psychology or mental health expert who can address those issues and see how they can signpost them and support them without those, before those distressing symptoms become a full-blown mental illness.
Wow. Thank you so much for taking on that topic. There is just one more question before we go to open panel. I don't know if it's Humphrey or it's Dr. Lola to address this. Priapism seems to be a very common complication in patients with people living with sickle cell. What is the right treatment for this, and what advice can you give to young male community members regarding this condition? How much it can affect the sexual life of the individual? Maybe for those who may, being a technical term, let me say for the benefit of those who, that priapism, we're referring here to painful erection, and that lasts longer than for erection where the penis actually hardens up for a lot longer, and sometimes uncontrolled and very painfully. That's priapism, just so I explain the terminology for those who may not be aware. So for you, the clinical experts here, there's the challenge. What is the right treatment, and what kind of advice can we give, given all the psychological challenge you can imagine resulting from that?
You want me to stress that, or?
Dr. Lola, you can go. You can have a go. And then...
As Dr. Asa'ah says, priapism is an involuntary erection of the penis, and often as a result of sickling in the penis. So it's nothing to do with sexual activity. It's as a result of sickling. And there are various things that people can do to prevent priapism. The youngest child I come across in my 30, almost 40 years experience is a child of a 2-year-old who used to get repeated priapism. And we tend to find it occurs more during the night or early morning, because when somebody's very warm and in bed, it tends to occur because their bladder is full. So we have different things that we advise to try and prevent priapism. So including things like emptying the bladder, walking up and down the stairs, taking painkillers, and things like that. And then if all that doesn't work and they get repeated, what we call stuttering priapism, if they get repeated priapism, there are things that we can do in terms of medication to help individuals to get over the priapism. If things get so bad that we can't relieve the priapism, individuals may have to have surgery to get rid of the blockage in the penis. And also it can leave some people, sadly, it can leave some people impotent and unable to have sexual erection. And that can be quite distressing for quite a number of people. What I usually advise is the first thing an individual should do is discuss it with their clinician. So when they go for their routine medical assessment, discuss it with their clinician. Ask more about what is priapism, how do I prevent it, and how do I manage it. There are leaflets available on priapism that you can get from the Sickle Cell Society website and other areas. And information from your healthcare professional is your best option, because I'm sure whichever clinic you go to, particularly in the UK, I'm not so sure, but obviously we're talking to colleagues or all over the world, and therefore you need to find out a bit more from your local area whether they have literature available that talks about priapism. But we certainly have on the website here in the UK, which I'm sure you can access.
Excellent response. As people can guess, we seem to be already sliding into the open panel. But let me just point out before I forget this, the technical team is reminding me that at the end of this presentation or the end of this webinar, please don't forget that you've got a survey to complete for us. It is important that we get some feedback as to how we are performing, so that subsequent webinars can actually be improved even better, to even better than this one. So, and while at it, let me just say that on the 27th of January, 2024, we'll be having our next topic, the next webinar, and that will be on organ and blood donation on the 27th of January, CamDocUK. Next one will be on organ and blood donation. So now we've listened to 3 subject matter experts who have actually addressed the factual basis that underlies the mental health, the challenges of mental well-being for people who are living with sickle cell disease. So I'm going to open the floor now and take more questions. I must say that there's a lady called Anne Chantal, it's a very recognized name for my sickle cell warriors around the globe, and she's just fascinating, the amount of information she's giving. And let me just ask Dr. Humphrey, given what you've actually explained here, because the way you dissected the mental well-being and mental health is so wonderful. I just kept thinking, is there any way CamDocUK, through you, could actually consider the possibility of those who don't have the fortune of living in the UK, they can actually remotely access your services through CamDocUK in those sort of challenging periods. I'm thinking here about some sort of a remote line where they can actually reach you, so that would they be giving would they be prepared to set up a small panel for real-time responses?
I think I'm okay, if CamDoc wants to collaborate with, Diaspora Cameroon, I'm happy to be a part of the process. We need to understand what resources to put on ground, be able to know how to pitch what we're offering to get the best fit. But like Marie mentioned, I think education is the key. For some reason, education hasn't translated to change in attitudes. So I think if there's anything we could do for a start as CamDoc is, whatever resources we have, flood those resources to schools, to communities, to see if that would, influence change in attitudes. And to answer your question, I'm quite happy to partner with colleagues in Cameroon to see if we could, start something remotely.
I hasten to point out that it's not for me to take a policy position on CamDocUK. I'm just teasing out the potential because I know that we've got the the corridors of power actually monitoring this presentation, and this is me putting them on the spot.
Yeah,
as we always try and play this.
You're right. As you know, I mean, I included the slide on prescribing because my experience, outside prescribing in some sections in Africa is they do it without guidelines. So we have to be very clear that there are guidelines in place, just to safeguard what we're doing as well. So if Cameroon can, our colleagues in Cameroon can agree to adhering to certain guidelines, then it will be safe for us to partner with them. I mentioned prescribing issues. I mean, I don't think they are as careful. Some of them are not as careful as we are. So you could see, the possibility of, medications that, may, interact and lead to possibilities. But I think guidelines will be the first place to start. We get clear guidelines on how we can operate and take it forward.
I know that there's a lot of questions coming through and we'll push for time. So I just wanted to tease that point. But let me just quickly point out that there are people joining this from Nigeria, from Uganda, from the US, as we've seen. So when we speak about when you mention guidelines, just so that we should reassure even those in Uganda that this CamDoc, if eventually the CamDoc hierarchy will adopt this sort of suggestion, it is something that we'll be working with the sickle warriors across the globe. In people like Asa'ah in Uganda, and those who are also joining from Dublin. There are people actually as we work, and there is various organizations around the world. So let's return to the questions. Dr. Oni, there is another question here asking about: are there any help? Are there any facilities, help, support for sickle cell community in the UK? How does the government help this group of individuals? I guess you and Marie will have some perspectives on this regarding the question is, how does the government help the sickle community in the UK? I suppose more or less, if it's an international question, people are looking to learning from what you're going to say.
There's been quite a lot of activity, particularly in the NHS, certainly in the last few years. The most current is 2018, when the government established what we call hemoglobinopathy coordinating centers and a national panel. And the objective of this coordinating centers is to monitor and ensure that provision in a regional area is adequate and monitored and established. Whereas before we used to have postcode lottery where, it depends on where you are in the country as to whether you can access good care. The whole objective of that is to ensure that people can access good care irrespective of where they live in England. If you want to find out a bit more about the HCC, the coordinating centers and panel, just visit the NHS website and look for sickle cell, and you'll find information on there. The other is, of course, the social support in terms of there are various support groups within each local area. Not every area has a support group, but a lot of areas do have support groups. If you want to find out whether there's a support group in your area, or you want to access a national support group, I think I put it on my last slide. You can go through the Sickle Cell Society website to find out and ask about a local support group if there's one in your area. And you can also have a look. There are other support mechanisms like the Sickle Cell Warrior. So different groups are available within England, within the UK, that people can access. Talking about those outside of England, there are support groups and groups that support people with sickle cell disease. For example, the Sickle Cell Foundation in Nigeria that I'm well aware of. And there are organizations in other parts of Africa that provide support, including Ghana, in Cameroon, I'm aware of, and things like that. So really, it's just to link in and find out where these services and these support services are available. And the Sickle Cell Society is a good starting point because they get to know even of some groups outside of England that they can link you in with, or link you with professionals in those countries that may be able to give you advice and support.
Interesting, and we know that there, as you say, there are sickle warriors. We should mention some of them in this panel, in this webinar. There are people like Asa'ah in Cameroon. There's Anne Chantal in Cameroon. So essentially, maybe these are groups that when we get their contact details, we'll attach them all to the CamDocUK platform, so that those who are actually interested in finding more, a little bit more about this webinar, could actually know some of those signposting directions. Marie, it is important that, given that Dr. Humphrey said that happiness addresses mental well-being, and Dr. Humphrey also said primary illness, it addresses mental health. Mental health, the way I like the way he dissected it. But what I want to find out is, given what Lola has just said, is the support, the solidarity, the importance of solidarity in ensuring that there's support for that person, the empathy for that person, and therefore they improve their happiness clearly. How does plasma of hope actually addresses this in the Midlands, so that this is more for the benefit of those other warriors who are out there who are actually joining in this webinar? How does plasma hope, because you discussed what you discussed in your presentation, you spoke about the impact on the individual yourself, you spoke about the impact on your family, and then the community, and which is where some of the motivation for you to starting plasma of hope, you see. So what are some of the elements that plasma of hope actually addressing?
Thank you very much for that question. Just to follow up on what Dr. Lola just spoke about, happiness is the key to a better mental state and a better well-being. From my experience, a lot of the times that I have been sick, I have been in very severe crisis. Just the fact that I have had people around me that care about me, that are waiting for me to get better, has given me hope. I am lucky to be in the UK, where I have better treatment than my friends and some of my family with sickle cell in Africa. But that notwithstanding, we still do have some challenges in the UK. Dr. Lola did mention the specialist centres that the NHS has created, but unfortunately, these specialist centres are quite central. What I mean by that is they're quite central to London. A few days ago, a report came out about really poor care and understanding and staff issues around nursing care for people with sickle cell disease. And the worst was in the Midlands, which is where I live. Bear in mind that in the Midlands, we have a lot of communities from Africa, a lot of people living here with sickle cell disease, but still there's very little knowledge about sickle cell. So the whole idea of plasma of hope was, from my experience, from the lack of understanding from my local area. I had a stroke in 2011 because I went into my local hospital with a crisis at about 11 p.m. at night. I wasn't seen by a doctor or giving any relief until 7 a.m. in the morning. That is how bad it is. So I had to do something about it. There are a lot of people around my area that are having newborn screening. For those who don't know, in the UK, every child born in the UK is screened for sickle cell disease and thalassemia. And a lot of these families are giving this screening without any support. You have your baby and the screening comes out positive. They have no idea what to do. So I have come across a lot of people that have struggled mentally. How do they stop? Relationships have broken down. dads have left moms and saying, oh, this has nothing to do with me. So my idea of setting up the charity was to support families that are going through the transition of getting into a different kind of life. By that, I mean, having a child living with sickle cell disease, having an adult, a teenager living with sickle cell disease, by me sharing my experiences of having lived in Africa and in the UK, and, just putting everything together, that the most important thing that we need to provide to these individuals is mental well-being support. And that's the key for plasma.
Yeah. As usual, very, very important. But let me just put a very, for the purpose of those who may not be here based in the UK, let me put it in context. Marie mentioned the issue about screening. Can I just say that there are standards? There are clear standards and guidelines that are supposed to be followed wherever they're happening. The reality we are faced in the NHS today is that the NHS is a victim of its own success. It is, I'm not a politician, I'm not speaking for the government, but we have to show some empathy. So before they do those tests and those things, because they're doing them because there are actually standards in place. Dr. Oni is here as for years, we went around campaigning to set up all those standards. And we knew, most unfortunately, because of the stress that the NHS is facing at the moment, it would not surprise me to hear those kind of anecdotal failures that you mentioned. But I just want to reassure people that if you look at the standards for screening, it's clear guidelines are there as to what should happen before, during, and after. So I just want to make sure I point that out clearly. Maybe, I don't know if, but the good thing is that an organization like Plasma of Hope, they are there to make sure that there is equity in the way healthcare is being delivered in the UK. So we spoke about earlier about the individual, the impact on the individual, the family, the community. And then these are some of the issues that we have to take the equity, bring it now within the framework of mental health to ensure that, yes, we already have a cure for sickle cell, and there is a cure. Bone marrow transplant is a cure. The other day we heard about gene editing is a cure. Not yet available for everybody because of the cost. Let us also transfer that into the other side of it, which is the mental health. So what we are speaking today, what we are addressing today, hopefully is further for people like Marie and people like all the others who are also watching, and Ashraf and others, to make sure they can carry this all the way and push that information further to the WHO, so that this kind of advocacy can ensure that mental health issues are given the due attention that they deserve. Dr. Enow spoke strongly there about happiness and well-being, the issue, the way he dissected it, both of them. So I'm saying that for the purpose of people watching this, what we don't want people to go away with frustration. Please, let us look at the information that's coming across and see how we can use that. And this is where CamDocUK can actually help. We will try and record this, we will record this, have it on our website, and we'll have all the signposting advice. So you, the advocates around the group, can actually access those resources from CamDoc and use them to actually challenge in their various countries, so that people can see, yes, the NHS is under stress, but with all the appropriate information, people in the UK are already living to normal life expectancy with sickle cell disease. I hasten to point that people in the UK are already living to normal life expectancy with sickle cell disease. Of course, the quality of life is what we're actually talking about here, which is mental health. So I just wanted to, it's very important that I bring that out before we move to the next question.
So before you go to the next question, I just want to make a comment very quickly from what Marie has said about, people not getting the support. That's the whole objective of having the Hemoglobinopathy Coordinating Center. If people are, finding that the services are not working the way they're supposed to, there is avenues for making complaints through the HCC. The HCC, if they're not aware of these things or failings, cannot then address the issue. And I think we need to educate our community better to understand what the HCC is, how to use it, how to access it, how to use the national panel to be able to recognize where the failings are occurring. If we don't tell them and we're not reporting these failings, then nothing will happen. So we need to be a bit more politically savvy in how we know how the system works and use that system to the benefit of our community. That's what we fail as Black people.
Wonderful. Anne Chantal, we are following you. You are really on point. You said education and information are key to change mindset, and this has to be targeted in every sphere of population. Anne Chantal, you've got it right on the money. What we need to do is create linkages between your organizations and the various advocates across the globe, so that we can use that, as you say in Cameroon, Union fait la force. So people need to come together. CamDocUK is there to help orchestrate, so that you can push the pressure at the level of WHO, while Marie and others are doing what they're doing in the UK. The next question, Dr. Oni, I think this one is related perhaps to Marie as well. They're asking, pregnancies in sickle cell more high risk? But before that, I just want to say, Marie, people are asking for your contact details. So don't forget to put your contact details up, because they're saying, please, can you tell us how we can reach you? Marie, that's all to you. And so many other people asking how they can reach Whereas we're going to have all this contact details on our CamDocUK website. So, Dr. Oni, are pregnancies in sickle cell more high risk?
There's been quite a number of research about, risk and pregnancy and what have you, and including fertility issues. But a lot of the research or reports that that have been reported in terms of sickle and risk, the risk is if people are not well managed. Like any other pregnancy, if you're not adequately managed, obviously you're starting with a bit of a deficit in that people with sickle cell disease are more anemic. They're more likely to have complications during pregnancy. But if they're well managed, there's no reason why women with sickle cell disease can't get pregnant, nor is there any reason why they can't have a baby and stay healthy. They're more likely to have instrumental delivery, like for example, forceps, or more likely to have cesarean section, and we're well aware of that. But the important thing is ensuring that they're well managed. One, they plan their pregnancy. So unwanted pregnancy is not ideal because it means they're starting with a deficit. So planned pregnancy. Secondly, ensuring that they're being looked after by an obstetrician and a hematologist that understands sickle cell disease. If you live somewhere that doesn't have that, go where they have it. That's my plea to anyone with sickle cell disease who wants to have a child, because that will limit the likelihood of complications occurring where the clinicians don't know what to do. So yes, there is higher risk, but a lot of my patients had normal deliveries, and had good pregnancies and good outcomes, and babies well, mums well. Why? Because they've been in a place that understands sickle cell disease and pregnancy. So unfortunately, that's the major cities like London and what have you. But if you live somewhere where it's the same with other conditions, if you live somewhere where there's not many people with that condition, the expertise is not developed. And so you have to go somewhere where there is that expertise, during the period of your pregnancy. So there is higher risk, but not necessarily so if they're well managed.
Wow.
Can I just follow up on that?
Yes, please do, because the next question was actually coming to you in relation to that. They did ask whether whether people who are carriers should get married.
Oh God. Okay. Well, this is something that we could talk on for as long as we can. But obviously, speaking from experience, I have sickle cell. I've got 2 children, and something that I wasn't prepared for. And I only realized this after, having gone through it. It took me a very long time to conceive and fall pregnant. A very long time, several years, as a matter of fact. And I went through all the medical interventions, and, for some reason at the back of my head, having lived and grew up in Africa, I was told that because of my sickle cell, I would not be able to bear children. So I had that. I don't know if it was a mental effect that was playing on me, but I just could not get pregnant. And then when I finally went through a process called IVF, which is we're lucky to have that system in the UK, PGD, which Dr. Asa'ah kindly referred me to. I only found out that due to my sickle cell, I do have something called low ovarian reserve, and apparently it is very common for people, common in people with sickle cell. this was a big problem. So because of that, I couldn't, but it so happened that, I had to take things into my own hands. And I was told, many people with sickle cell do fall pregnant and have healthy babies. I was told that as a result of my complications, I would not be able to get pregnant. And I had to look into surrogacy. But for some reason, I refused to do that. So I had to do my own research and made a lot of lifestyle changes. And I got pregnant naturally. Then I got pregnant. I faced different set of challenges. And just to add on to what Dr. Lola has mentioned, throughout my pregnancy, I was monitored constantly. And as someone that lives with sickle cell, it is important that your consultant or your obstetrician put you on low dose aspirin from about 12 weeks, if I'm right, or I don't know, Dr. Lola, is that correct? Or heparin or hexane is like a blood clotting medication, because with sickle cell, we are prone to blood clots during pregnancy. So I was put on a low dose aspirin, and also to reduce the risk of preeclampsia. People with sickle cell have to be very mindful when they fall pregnant. And just to say that if you shouldn't get married, that is not something for me to address. I think what we need to be mindful of is the mental health implication of stopping people to become friends with each other. What I believe the important thing for us to do is to educate people about the complications of sickle cell and the support that is available. If you do happen to go ahead and get married, you are doing that with informed choice, and making an informed decision, I beg your pardon, having been presented with all the information. It is up to you to go ahead or not to go ahead and get married. So I will not advise anybody to or not to get married.
Wonderful. I know we are really, we could go on and on the questions. I just want to acknowledge Reverend Sister Delphine Agbo. You are effectively emphasizing the point that Anne Chantal has actually made about the need for education and enlightenment is the key. That's why we're here. We heard from the subject matter experts. Dr. Humphrey Enwo has actually dissected the whole basis of the psychological management of the mental well-being of people with sickle cell. And even before that, we got all the factual information, and even from the answers, Q&As coming across, we had the answers from Dr. Lola Oni, member of the Order of the British Empire, fellow of the Royal College of Nursing. We heard from the consultant psychiatrist, Dr. Humphrey Enow. We can go on, and the questions are pouring in, and we will address what we can and put on our website, CamDocUK. I think I will plead with Marie that as a person who effectively originated the idea for this particular webinar number 18, I will plead that you please give us the final comment. But before you do that, I just want to remind people that please go on and address our survey. The survey is very important for us because it gives us an idea of how we can actually do the next one even better. So Marie, while I thank everyone for joining us today, my fellow moderators, Dr. Anna Mbene, Dr. Christian Dimala, all the way from USA, the technical team, Dr. Boncho Morgan, who is the previous chairperson of CamDoc, handing over to Dr. Linda Bello. We have Dr. Anna Mbene, who is the communication secretary. We also have, I mentioned Dr. Valentine Ngwa, who is the education lead. Chief Asa'ah, the head of the international committee at CamDocUK. So thank you all so much for listening. But before you go, let me get Marie to give us the last word. Marie, you've got the next 1 hour.
Thank you. Be careful. I won't stop. Thank you so much. It's been an absolute pleasure to be able to present to and share experiences with every single one of you here. The message I want us to take away tonight is that sickle cell might be a dilapidating condition that is killing people across the globe. Mentally, we need support from everyone around us. People are living a good old age with sickle cell disease. We always fear that we're going to die. At the end of the day, every single one of us is going to die, whether you have sickle cell or not. So the least we can do is provide support and care and understanding to anyone we come across that lives with sickle cell disease, because sometimes they might not be able to share their experiences due to the stigma that they have lived throughout their lives. This has been a fantastic webinar, and all we can encourage is that we keep spreading the word. It would not be a stigma if we keep talking about it. So the onus is on us to keep educating and educating. Thank you, everyone, for attending.
Thank you, Marie.
Yeah, thank you.